So welcome to everybody for coming. My name is Adrian Viens. I am the director of the School of Global Health and an investigator in the Global Strategy Lab at York University. As I think you may be aware, it's World AMR Awareness Week, as well as the first anniversary of the AMR Policy Accelerator. So a very fitting time for us to hold this webinar. AMR presents a formidable global health and development challenge, making collaboration between researchers and policymakers not only beneficial, but essential. So our panel today will explore challenges and opportunities for evidence-informed AMR policymaking. I'm going to begin by asking panelists the question, what they see as primary challenges bridging the research policy divide. I'll then ask some individual questions to our panelists, then I'll open it up to people in the audience. And so when it comes to that time, people can please use the Q&A function to be able to ask questions rather than the chat. I'd like to begin by introducing our panelists. So we have Dr. Ifedayo Adetifa, who's the Director General of the Nigeria Center for Disease Control and Prevention. He's a pediatrician and epidemiologist with almost 2 decades of work experience in general pediatrics, pediatric infectious diseases, and infectious disease epidemiology. We have Professor Clare Chandler, who's Professor of Medical Anthropology at the London School of Hygiene and Tropical Medicine. Her research is primarily ethnographic, but also incorporates historical, epidemiological, and interventional approaches. We have Dr. Zubin Shroff, who leads portfolios on health financing and emergency preparedness and response for the Alliance for Health Policy and Systems Research, a WHO-hosted partnership dedicated to promoting the generation and use of evidence for stronger health systems in low and middle-income countries. And Dr. Susan Rogers Van Katwyk, who's managing director of the AMR Policy Accelerator, where she leverages her extensive experience in global AMR policy to oversee the development and implementation of the Accelerator's program of research. I also like to invite those of you who are in the audience to introduce yourselves in the chat to be able to get to know each other, as well as just let you know there'll be a short feedback survey at the end of the webinar that we would appreciate you completing at the end. So to begin, I'd like to be able to ask the question to our panelists, maybe speaking for 1 or 2 minutes, and to be able to address the question of what you see as the primary challenges of bridging the research policy divide. Why don't we start with Professor Chandler?
Thank you very much, and welcome to everyone to the webinar and to World Antibiotic Awareness Week. I've said it wrong. World Antimicrobial Awareness Resistance Awareness Week. So primary challenges, and clearly in getting the language right, as we all know. I think I would just say one primary challenge that I think that that is a real challenge, but also an opportunity, is working together between researchers and policymakers on solutions to antimicrobial resistance. I think we do a lot better at the moment in conveying the problem of antimicrobial resistance, and we do well at conveying a whole range of different solutions, but helping policymakers to decide what they should invest in for the greatest impact that's going to minimize the burden of antimicrobial resistance is an area that I think we could do a lot better on the research side. And I think it requires a collaborative approach across research and policy to really be able to come out with what are the solutions, what are the interventions that should be being invested in any given scenario, so that within the short term, the medium and the long term, we're looking at an improved situation in terms of who is shouldering that burden of antimicrobial resistance. So for me, that would be a primary challenge, but also opportunity.
Great. Dr. Shroff.
Thank you for the introduction, and great to be here. I'm speaking from the perspective of a health system specialist more than an AMR specialist. So I'll be speaking more to the broader questions in the research to policy space that I think have broad applicability to AMR. I think it's important to realize that the generation of research and policy implementation and development are 2 separate worlds, and we try to bridge it and have fundamentally different incentives. And these incentives actually accentuate the challenges. And therefore, getting the incentives right is actually important to get over these challenges. So the first challenge is how to produce knowledge that is relevant to policymakers, not only in a given context, but also at a given moment in time. And policy processes are all about windows of opportunity and taking advantage of those windows of opportunity. And it's about moving from It's about trying to find ways to do research in a more collaborative fashion that is co-created and co-produced rather than completely isolated, which is going to be essential if you're going to take advantage of these windows of opportunity. The second challenge is just linked to this is how to provide knowledge in formats that are accessible to policymakers. And here it's about going beyond the peer-reviewed literature. How should researchers engage in policy dialogue processes? How should they engage in developing products that are really not in the peer-reviewed domain, but are still rigorous research that can actually be used to inform policy making? What are the formats and the importance of actionable recommendations, which Clare also pointed out. And the third challenge is how to bring about a mindset shift amongst policymakers to be open to the use of evidence to inform their policy decisions, particularly when it goes against the received wisdom or perceived self-interest. And this is linked to capacity strengthening amongst policymakers to use research evidence. We have a lot of policymakers who have a research background. And Ifedayo and I have been on a panel last month. Of course, he is a researcher now in policy, but that's not always the case. And it's important here, as I brought about incentives. No one's going to do this without a shift in incentives. If research funders are serious about policy impact, they need to fund research to go beyond measuring purely high impact publications produced as a result of research, and they need to look to be more creative on that. Universities need to find metrics to incorporate policy impact into career promotion and career development opportunities for researchers. It's quite perfunctory and symbolic currently as it is in most Western institutions, where really promotions are based on purely on journal metrics, which don't really take into account policy impact. And within the policymaking space, there's a need for incentives at both individual and institutional level to actually use policy evidence. And this includes, for instance, making evaluations mandatory when you're rolling out new programs. We have instances in Mexico, for instance, where it was put into law with the Seguro Popular Health Insurance Program. You also have to look for other things, such as actually at least perfunctorily ensuring that when you're bringing in a new policy, there is a statement of what evidence was perused. And this is going to be a long-term process of creating a culture of evidence use. And then also finally, I'd like to add, it needs experience of researchers and policymakers working together and funding that sort of approach to doing research, which can actually help create this culture of evidence use. Thanks.
Right, thank you. Dr. Adetifa? Can you unmute yourself?
Okay, thank you. I think between Zubin and Clare, a lot of the points have been covered. I quite like the idea and align with the idea that the incentives obviously between researchers and policymakers are completely different, and often again, depending on which context you are, they are so different as to confer basically status of different species basically on the two groups, and sometimes you really can't bridge the gap between species depending on what the interest is. But again, to come closer to home, I think it's essential. These guys don't speak the same language. There's the internal search, and I say it's internal or OND search that researchers have to set out to do to find at any point in time what is the relevant language for this time, for this, whether it's AMR that we're speaking about or something. What's the language for this particular time, this particular policymaker, and even the context of at the time, and that's why I've said it's the next next search or the next holy grail for researchers who really do want to see the impact of their work on policy. This is what they now have to sign up to do as well. But again, I think the other thing for context is, as a researcher, as an epidemiologist, I see the value of synthesizing data, of systematic reviews of global burden of disease studies, and all of the very brilliant modeling that goes into fill some of the data gaps. Sometimes to the extent where they are actually almost like guesswork. But I find that policymakers, and in many countries, they relate more to their own data, and often that's not available, or when it's available, it's not at the scale where it has external validity or can be generalized to make informed action for the entire country. So it's key to perhaps I don't know where that will happen, where researchers to take a step back and everybody else and encourage local data collection. However difficult it might seem, but I do recognize that research grants have lifespans. Most projects will be funded for 5 years or less, or in fact 2 to 3 years. You might be lucky to have sort of like the Wellcome Trust fellowships that now go 5-7 years, but this is not common. And often this now requires a program of work that may last a particular researcher their entire lifetime just to go from a hypothesis or research question to generating the information that they need to, that will speak to the policymakers. So I'm going to stop there. Thank you.
That's great. Thank you. Dr. Rogers Van Katwyk.
I really like this conversation about collaboration that's happening, because I do think that really gets to the heart of this matter. And for me, I see sort of 3 big challenges for collaboration. The first one is that we need to find a way for researchers to work with policymakers in government to figure out what challenges governments are urgently working on right now, where they need evidence and where researchers can support them with that evidence, whether that is big systematic review, evidence synthesis kind of evidence, or local on the ground, super targeted evidence that is going to help them put a policy into place. The second challenge is how to figure out what the challenges of the future are, so that researchers can be ready with evidence to support those actions and those policy decisions when we get to them. And there are all sorts of issues on the horizon that we know are going to become a challenge, and we do have to be ready with research to kind of face those challenges as they come. And then the third thing is that we need to figure out how we do research on policy, so that we can kind of work with policymakers to almost conceptualize policies as a public health intervention in themselves, and figure out how do we know whether those interventions and actions are working. How can we evaluate them in a rigorous way so that we know how we can make those things better over time? So we know that we're not wasting time, wasting money, wasting a lot of human resources on a policy intervention that isn't going to have the kinds of positive impacts that we are looking for at the end of the day. And so this collaboration challenge kind of circles around those 3 things. It's the urgent research now, it's the research for the future, and it's also that research on what we're already doing so that we can make those kinds of continuous improvements over time.
That's really helpful. Before asking some individual questions, maybe I'll open up a question to the panel. I think we know that policymakers are faced with many competing thematic priorities. And so how can researchers communicate the urgency of addressing AMR now? For anybody who wants to jump in. Not all at once, of course. Yes.
I can jump in. So Professor Chandler mentioned this right off the top, and I think it's a really important point, is that we're really good at explaining the doom and gloom of antimicrobial resistance, and we're not very good at explaining how people can have positive steps to address that challenge for the future. And that is not at all helpful when I want to go to Dr. Adetifa and say, I have suggestions for what can be done in country to address AMR. Because if all I come with is, this is a big problem and no solutions, then we're not going to get very far. So for me, I think some of the key pieces are around showing how important antibiotics are to health systems. And there's no one better to talk about that than Professor Chandler. but also trying to show how important antimicrobial resistance is in the context of the other big health issues that we're dealing with all the time. The ability to provide care to patients in countries, trusting government, overlap with pandemic preparedness and tuberculosis and cancer care and all of these different pressing issues that are parts of the mandates and the budgets of public health organizations around the world. And so we need to be able to contextualize AMR as being part of that ecosystem, where action on AMR also helps us take action, make positive steps in all of these other health issues as well, and find those steps that are actually actionable pieces of the puzzle, rather than just sort of saying that this is all doom and gloom. It's much more helpful if we can come in and say, you know, we're looking for is investments in clean water and sanitation, or hospital sanitation, or universal health care, so that people continue to have access to these kinds of life-saving drugs around the world.
Anybody else want to jump in on that?
I might just go quickly comment on. So the question asked, how do we communicate the urgency of addressing antimicrobial resistance now? And I do think it's probably worth, you know, as a social scientist, pointing out the implicit tone of saying that we need to communicate about the urgency now. We have to remember that there can be fatigue for perpetually saying now is the time. And we know with confidence that we will be living with AMR in the future. To address it means minimizing its impact or its burden with actions that are now for now and actions that happen now for the future. So I think we don't want to kind of give an illusion that this can be reversed or eliminated or is not going to be a problem in the future. So I think we can do better in the way that we talk about AMR, the temporality of how we talk about it, because we will be inviting critique of, you know, in the future, if we set this up as something that is imagined to be solvable immediately. The solutions to this aren't solutions that stop it happening. The solutions mean that we minimize that burden and we minimize it on the people who are currently shouldering that burden. So I think the way that we talk about it has to kind of have that as part of it. And in the way that we assemble what we know and what we know about what works needs to be put into that kind of, you know, long-term strategy. It may sound boring, but when you're working with policy, that also is boring. It's about planning. It's about saying this is what's going to happen. We know with certainty some things and we can plan for them, and these are our solutions to them. So I don't think all policy needs to be exciting, urgent. You know, we do have to act now, absolutely. But we're not acting now because we imagine it's going to be over.
If I might just add, so I'm conscious that from where I sit, even in the policy sort of spectrum, I still don't see the full picture. I certainly would like to spend as much money as I can get on health security or AMR response, but the larger issue is that we're trying to appeal to somebody who sees the entire pulse and knows how much is in that, and has to deal with education, has to deal with you know, security, has to deal with roads, housing, and all of that. Is what information do we really need to have available to make this central figure, who is not a healthcare worker, or even if he or she was, they've now moved on to other things. They certainly cannot, you know, they don't need convincing about the science. They don't need convincing about the impact on lives. But the issue is, look, I've got X, and now I've got to split it, or slice this budget into a number of pieces to cover everything. And so the question is, you know, that I struggle to answer is, what do I need to say? So it's one of two things. Is one, I think perhaps more than ever before, it's important to get the people's voice, the people who have survived AMR, the ordinary person who casts the votes, and the advocates who can really make government pay attention, because it's like you either sort out this aspect of healthcare, or we vote you out of office, or make your life miserable, kind of thing. So that's one. The second bit, I think, is all governments recognize dollar signs. So can we pass the message as one that actually, if you intervene by doing ABC, this is the basic scenario, this is the next intermediate scenario, this is the advanced, this is how much you save or how much you return to the economy, or, I think a lot of the guys we depend on. So my challenge is not convincing my minister. My minister understands AMR. In addition to all the other problems he has to look after in the healthcare sector. But the Minister of Finance and Budget and National Planning, they don't understand AMR. So it's, how do you break that out into terms that means, okay, your budgets will suddenly, you will have more, or you will gain this much. I think this is the information that we really need to try and work on to provide to policymakers. And these guys do not necessarily respond to, and this is where I agree with Professor Chandler, they don't necessarily agree to the argument about now, because you can't back that up. They're not seeing it. It's not immediately affecting the bottom line or the GDP or so, if you, and all of us will go to them and say everything is an emergency. Lassa fever is an emergency, cholera is an emergency, and AMR is like, okay, the word emergency is just a standard suffix for everything that you bring forward now. And at a certain point in time, then they disregard it and start to look at other ways to determine what is actually important to intervene in at the moment.
Actually, do you want to quickly go on, Dr. Shroff?
Yeah, just, I mean, there are great points and suggestions from everyone else. I think two things I wanted to add to this. One is, of course, the importance of framing the problem in a particular context. A lot of the discussions are very global in terms of 50 million, 10 million deaths a year, $50 trillion. I mean, and I think, as Ifedayo pointed out, you need to have localized information at a very granular level to make it real, because policymakers' jurisdictions are still, and their accountability lies to populations, whether at national or even subnational level in large governments, and then they're responding accordingly. And the other is probably staging one's interventions. This comes to Susan's point of coming up with tangible solutions. And you're beginning to get by interventions which are within the domain of one sector, or at least possible to address it at national level, rather than coming up with global things that require transnational action, which are, of course, important for addressing the whole suite of things that AMR has within it. But if you're coming up with something which is actionable within a Ministry of Health's domain, or largely within a Ministry of Health or a couple of ministries' domain, it's probably easier to actually make that case to begin with, and then sequentially go to look at interventions that require more holistic action across sectors, because multi-sectoral action, as we all know, is easier said than done.
Then this relates to a question I want to ask Dr. Adetifa. So thinking again more concretely, so like, what sorts of evidence do policymakers actually find useful from researchers when trying to create better policies? How can we, again, try to have that policy impact we've been talking about?
Okay, so we all, I think everybody likes factual information or stuff that's concrete enough to support decision making. So from quantitative data and trends from your surveillance, and of course that can be complemented by the forecast and modeling. I think beyond sort of the burden, the data you need to make a case, I think now, as I think somebody suggested in the chart, is we now need information on sort of what the most viable solution is for your context, and this whether, of course, categorized into near and long term, or a stage response will actually also be useful. As I said earlier, evidence that is context specific and applicable to the specific circumstance at the time you want consideration is probably most important. You do not always necessarily want to hear about what works elsewhere, or you know, because then it becomes less real to you. It becomes a bit of another story from somewhere else. But if you can contextualize and use local data to show the full extent of the problems and what would happen when they go away, then that will find, or what works in a similar setting. So if you tell me what works in Australia, or you know, I don't relate to Australia, but if you perhaps tell me what the South Africans are doing, or the Kenyans, or the Egyptians, or others in West Africa, then that might be more important. Yeah, there's some soft things to consider, like who the researcher are, what knowledge we know, or what's their reputation or credibility, you know. But again, I think it's important to ensure that all of this evidence or case that we present are distillates. They are really fully condensed and straight to the point, because guys do not have the time in the midst of competing priorities to digest long fact sheets and all of that. I think the part that a lot of us, if you say, including myself, quantitative folks never remember, is how much, well, health in general has social and behavioral components, and perhaps for antimicrobial use or antimicrobial stewardship and consumption, they in countries where, you know, both from the perspective of the citizens, there's been really unregulated use of antibiotics, and again, from the perspective of the health practitioners as well, there's not been as much evidence-driven use of antibiotics or antimicrobials. I think it's important that we do the work that is required to address sort of elements of human behavior that can be leaned on to bring about change, in addition to regulation and everything else that needs to occur in between. I hope this sort of addresses your question. Back to you.
Thank you. I think it leads very nicely, and I was going to ask Professor Chandler, you know, we've talked about the importance of the multidisciplinary, interdisciplinary work that is needed. How do you think we can kind of convey the knowledge, the learnings that we're getting from the social sciences, so they can be considered alongside the other kind of surveillance data and the other evidence that we use in policymaking processes?
Well, of course, I'm going to say the social sciences are very, very important. And in some ways, I think in this particular area have been, you know, really have been taken quite seriously already. You know, there's quite a lot of work. You know, there's a lot of work on awareness. There's a lot of work on behavior change and so on. So I think to a degree, we've seen quite a lot of useful intervention from social sciences to the overall policy response. I think actually what I would say is that although we do need to be communicating to policymakers and working with policymakers, what I would actually like to see is much better collaboration between social sciences and the other people working in the AMR space, so that we collaboratively say something useful to policymakers. I don't believe that every bit of science or social science needs to be communicated directly to a policymaker. I think that's overwhelming and potentially unhelpful, potentially harmful, because it can overshadow other important information. So, for example, saying, you know, people believe antibiotics can cure pain, and that's really problematic. So we need to correct that. If I came with that piece of information from a social science study, that would then misrepresent all the places where that isn't the case, and it would might outsize that compared with other interventions that may have a better impact and not have unintended harmful consequences of perpetuating incorrect belief models and so on, where we kind of imagine people as being in a knowledge deficit model. If we keep repeating those kinds of tropes to policymakers, then that reinforces how we, the people with superior knowledge, treat them, the people who we imagine to have inadequate knowledge. So I think we have to be very careful how we pitch what we have found in social science. And I think we need to be careful how we do that collaboratively with others, so that when we're presenting policy proposals, that those are really the most impactful for that context. You need social science as part of that package to know what's going to have the best impact, and to know the other impacts that might have that you might not consider from a different disciplinary perspective. But I don't think we should be all firing directly into a policymaker's inbox or knocking on the door. I think that's not an appropriate response, and we should be collaborating better together to come up with policy solutions.
Right, that's very helpful. Maybe to ask Dr. Shroff, I think research models are often considering bridging this gap between research and policy. They do so via push and pull models. It'd be really useful to hear what you think about other opportunities that could exist to actually gain more meaningful engagement.
So thank you. And I think the challenge with both the pull and push models is that it gives sort of sole space to the evidence itself, without understanding the sort of context in which who produces the evidence, how it's presented, how it's produced, how it's disseminated, and the kinds of structural and power and political relationships between the different actors that actually frame the way evidence is received. So both this push, which is largely about giving evidence to policymakers, the pull, which is capacitating policymakers to demand evidence and actually use evidence. These approaches, and there's some mix of these two, have been how we've traditionally conceptualized policy uptake and research to policy processes. And there are four things, I think. It ignores how evidence use is influenced by incentives at both individual and institutional level. It doesn't look, or it ignores power imbalances between researchers and policymakers in terms of who frames questions, whose knowledge is more valid, who decides what is to be done, how it's to be done. This is not to say that researchers don't have specialized knowledge, but on the other hand, there are insights from policymakers that can be very useful to informing the way in which we design our research studies and the way in which we conduct research. It underplays the importance of politics in policy processes and the windows of opportunity that I just mentioned earlier. And it also ignores the fact that evidence to policy processes are not one-offs, but exist within larger ecosystems of learning, where there are relationships between policymakers and researchers, and particularly within countries where these sort of relationships and links really influence what gets taken seriously and what does not. And an approach which we have been pioneering is that of embedding health systems research into policy processes. And what does this mean? It means primarily three things. It means genuine partnership in the development of research in terms of identification of research priorities, coming to actually developing specific research questions in collaboration with policymakers, ensuring that it's integrated in particular health systems context. So it's not like just identifying thematic priorities divorced from, say, a policy or a program, but within a particular intervention or a program of work or a particular implementation challenge, and taking into account context to ensure the relevance of the findings to policymakers. And this engagement does a lot of things. It ensures the relevance of the national ownership, which is great. It means that you actually have insights in developing the research itself and providing inputs to how you frame questions, where you should study things. Again, there are questions of how you need to maintain neutrality in this process. Obviously, that needs to be taken into account. Ensuring that you have a ready audience which is there. You don't have to actually do the research translation because it's already embedded inside the ecosystem in which the policy processes are implemented and designed. And that you actually obviate the need for active dissemination because you're, again, have a ready audience which is there to take up this work. And the aim of this approach is really to develop an ecosystem where policymakers in a particular area, say a thematic area such as AMR, are linked to a research community that is capacitated to carry out research in response to their policy needs. And this sort of trust that is built through this engagement actually helps to break down the barriers between research and policy and ensure that what research is produced is actually, Ifedayo did mention about where the source of the research really does make a difference to whether people take it seriously, and actually helps to sort of bridge that divide and form an organic whole of an ecosystem of learning within a country. It's not a one-off process, and it's a challenge to do this. But I think it's important for research funders to test this as a model and actually work with partners in countries, both policymakers and researchers, to actually develop such a learning ecosystem going ahead.
Thank you. Very helpful. I think this is right in your wheelhouse, Dr. Rogers Van Katwyk. I mean, if we think about with so much evidence that's going to be available, how can policymakers really be sure that research is going to be rigorous and robust?
It's a really interesting question. And I think the first point I want to make is that policymakers make decisions on a wide range of considerations. And as a researcher, I sometimes want to just say, like, look, I've identified a problem, I'm turning it over to you, and now you can go and solve it. But that's not how the real world works. There are other competing health priorities that come into that equation. There are some political considerations that come in. There are some budget-oriented considerations that come in. And so we can't expect that what we find in an epidemiologic study is going to immediately lead to the intervention that we think is the right thing from our sort of individual point of view. And I like Dr. Shroff's sort of characterization of an ecosystem, because I do think researchers, we're in this mode where we have a piece of research and we are trying to translate it, and it's sort of a one-sided thing. But for policymakers, they are interacting with a lot of different researchers, being fed a lot of different pieces of information, and integrating that is one of the key challenges. That said, I think from a research point of view, there is a lot we can do to sort of help with that situation. So we know that budget considerations are going to be key. We know that equity analyses and things are often going to be key. So to the extent that we can build our research projects to include some of those economic evaluations or equity analyses alongside whatever other epidemiological or social information we are capturing, that does help make a study sort of more robust, more compelling. There's more information there for policymakers to work with. And that, of course, is going to mean partnering with people that are in other research fields and getting together and collaborating on some of these projects as well. And as Professor Chandler's already highlighted, there's so much that the social sciences can bring to this equation. And I think that's really key, is to make sure that we're doing that kind of interdisciplinary work. I guess the other key thing is that we do want the research that we base our policies on to meet certain quality standards. And that's a challenge to do, because sometimes the easiest study to do is not the one that is the most rigorous. It's going to have some of the flaws and the biases that Professor Chandler mentioned off the top. And I think that brings us back to this piece about collaboration between policymakers and researchers, and really understanding what kinds of evidence they need in order to make decisions. Because while their policy research isn't typically randomized, there are lots of other sort of methodological tweaks that we can make to a study to make it more rigorous. For example, maybe we can't randomize who gets an intervention, but we can randomize when they get an intervention. And there are all of these things that the research communities can bring that help strengthen that science, that help make sure that when we see a pattern in the data, it's not something that we think is there just because of pre-existing trends or something else that's going on in the world, but it becomes something that is a little bit more reliable. And then, of course, bringing that in, we do rely a lot on systematic reviews, and there's a lot of value that can bring. But remembering that we do want some of these really high quality studies to be about the local context, or at the very least try and bring in evidence that is, as Dr. Adetifa said, from similar countries, similar health systems within the region that can make a more compelling case for action than something that is halfway around the world in a completely different health system as well. So I think there's lots of room for collaboration there, lots of room where understanding what the challenge is and what kind of data is needed can help us plan a study that will be rigorous, that will be robust, and that will actually help inform the policy decision in a more meaningful way.
That's great. I think, one thing that's really, I think, useful to be able to hear from the panelists in terms of whether there are some examples of successful knowledge mobilization efforts in regards to AMR or just even related areas that you've been involved in. I see there's a question in the chat about whether or not AMR research funders should include knowledge translation components within the project. So maybe you could talk about, again, either successful knowledge mobilization efforts, or again, thinking about this question about the inclusion of knowledge translation components by the of AMR research funders. Open it up to everybody who wants to go in. I think we're all looking for those, we can build on the successes of useful knowledge mobilization activities. So if anybody has the knowledge to share, we'd love to hear that too.
Shall I give an example of a social science one? So this is an example of us moving, which you would all recognize, moving the dial on our language about not just World Antibiotic Resistance Awareness Week, which I can't manage, but our language on how we talk about rational drug use. We have moved from talking about that dichotomy between being rational or irrational to talking about optimizing antibiotic use. That is quite a significant shift, and we all know why we've done that, because we were essentially, in a summary, blaming the victim. We were saying people who actually didn't have a choice were choosing to be irrational, and that we just needed them to stop. And I think that, we'd had decades of social scientists saying, we, challenging this rational actor model, which has been underpinning a lot of strategies and communications. And it, as I was saying before, it kind of can contribute to that reinforcing the superiority of those who have and haven't got knowledge and so on. It also shifts attention away from the structures that are inadequate, whether that's healthcare provision, WASH provision, vaccine provision. But by shifting that language, I do think we've also shifted the conversation. We now do talk a lot more, and we've seen that in what we've been talking about today, about that much wider set of issues around healthcare provision, WASH, vaccine provision, so on, those things that are absolutely essential for dealing with AMR. So we're no longer just talking about, imagining people as these irrational actors that are going around inappropriately prescribing or inappropriately consuming these medicines. Although we do still see that, and there are still some areas where that may happen, I think that shift in language is representative of a shift in the way that people think. And I think that has come from a lot of, loud noise being made by certain areas, including the social sciences, about what negative impact that has, both on how we portray those people and what we end up missing. So that would be one area I would suggest that we've seen some kind of successful knowledge mobilization from the social sciences.
Great. Any other examples people have to share?
Just an example that builds on that, about highlighting how important knowledge mobilization is and how it's not sort of a one-off thing. There's a great study that was done here in Canada that was looking at the appropriateness, the guideline concordance of prescribing for gonorrhea. And the concordance of prescribing was quite high up until the point that the guidelines changed, at which point concordance absolutely plummeted because nobody knew that the guidelines had changed. And it took more than a year to even get back to that point where most physicians knew what the appropriate treatment was for gonorrhea at that point. And so that really does highlight that, knowledge mobilization about resistance patterns led to a guideline change. That's great. That is a huge first step. But if it stops at that point and you don't do the extra step of knowledge mobilization to make sure that everyone is aware that guidelines have changed, then you're going to fall short of that ultimate goal as well. So I think it's important to see how knowledge mobilization is part of this ongoing strategy. It's not one and done. It is something that needs to be integrated and thought of as part of this whole public health process as well.
I see the time. I think I just wanted to also ask Dr. Adetifa, thinking about, again, policymakers may having their own in-house technical expertise, obviously supporting and developing policy. We might think about what they have access to in terms of surveillance data, national surveys, etc. But to think about kind of what additional evidence can external researchers contribute and support in that policymaking process? And what do you think, especially in the relation to AMR, that we can think about, again, this additional evidence? What can we as independent researchers based in universities, based in other academic scholarly centers, how can they contribute to that policymaking process outside of what is available to policymakers?
That's a good question. So I think that external researchers or groups typically have something that that is not in large quantity, that is not usually where the policymakers are. So whether it's advanced big data analytics skills or advanced data analysis, including modeling and synthesis and all of that. I think these are welcome skills that external researchers can bring, because often, we may complain about the absence of data or the absence of, but sometimes policymakers actually have access to a lot more data, just not in the form that is usable. It's all that surveillance data that sometimes is generated, or they are not immediately available in form of results, either because in my context, I'm chasing my tail, looking after outbreaks and less likely to commit to elective tasks and the like. So that's, I think it's useful to, for that to happen. Also, as part of it, setting up a relationship of trust and moving towards co-creation in terms of research priorities and research to be done. It's nice. There's a lot of data management or health informatics skills that are available out there. And sometimes what the national systems or regional systems need is a bit of a tweak to what they have going on, so that it's better, it's efficient, and it's, generates maybe better quality data, which is a little investment to make, considering that all of us consumers on the other end are then likely to have even much better data to access when the data is collected as well. And I think the question about giving an answer, helping to arrive at an answer about the potential impact of the policy you're either recommending policymakers to make, is a very important one. So you like to bring, it would be nice to bring all those skills to show what are the, for example, what are the health, socioeconomic trade-offs for doing one thing versus the other, and if there are any unintended consequences as well, to be able to paint that and be able to have a full picture of what needs to be done. I'm not sure it's related to the question or in general, but it strikes me that often there's a lot said about antimicrobial resistance and all of that, and perhaps not enough being said about that. You need to make a diagnosis. Is where's the investment? Where's the conversation about the diagnosis? Whether it's good old conventional microbiology, which has its problems, or the world has moved. Perhaps we should be not thinking about people starting off with basic tools. Is can we move along to using more advanced methods depending on scale, obviously, and others to make diagnosis and that. And perhaps this is where external researchers, not just external researchers, but perhaps even the private sector and others can actually come on board to help advance this cause that we are all trying to move along. Back to you.
I think I want to get back to one other question in the audience. We have a question here about how do we get policymakers to buy into investing in research requirements, such as equipment needed for new drug discovery, research from local natural resources, in particular, talking about the balance of pending challenges. We're in places we talk about food shortages, high cost of living, etc. So again, given the competing priorities, given obviously the way in which we're competing for resource dollars, how do we get policymakers again to buy into investing in the research requirements needed for new drug discovery? I'll open up to anybody.
I guess the short answer is it's difficult. it's you know, Joshua, who's asked the question, has listed all of the other things that are competing. The equipment for drug discovery versus tackling conditional cash transfers to either address food shortages, all of that. I mean, the answer is obvious. The equipment will not win the next election or keep the government in power. So the question about funding research, including providing high-end equipment, is one that has to be captured within an overall argument of investment in R&D and how that will contribute to societal advancement and economic gains and all of that. I'm not sure that will fly under just the AMR argument. So, you know, if I could just offer my 2 cents on that question.
Anybody else? I know, Dr. Katwyk, you talked about this earlier in terms of trying to focus in on what people are already caring about or prioritizing and bringing out the AMR relevance for that. And so that it's not a separate consideration. It may not be considered a competing consideration, but they're one and the same. I don't know for anybody else, maybe even Dr. Shroff, thinking about the context, I think you've done a lot of work in India. Are there particular considerations that we might have in terms of thinking about strategies for being able to, again, allowing this kind of prioritization, or at least getting this on the agenda for policymakers?
I mean, I think that the challenge is things like drug discovery are so capital intensive, right? I mean, and again, for things like drug discovery, there's a greater transmissibility across settings. So, I mean, unlike improvements to policy where context sensitive knowledge is particularly important, the questions about developing new drugs is not necessarily something which needs each country to invest in separately. And I think there needs to be some sort of rational use of resources for this. And a recognition that you don't need to have context-sensitive research on this, right? I mean, this is an area where the human body is fundamentally similar across settings, and drug discovery is not something which is often worthwhile for countries to invest in from scratch. And I think there's a need to really prioritize at national level what makes sense in a given setting. This is, of course, not to say that the recent efforts around investing in capabilities of, say, vaccine development in LMICs isn't worth it, but there is a need to prioritize, particularly around new antibiotics. When, I mean, you have HIC economy struggling to, and with all the laboratories we have struggling to develop new generations of antibiotics, is not necessarily the top priority for each country to actually invest in drug discovery per se, which really differentiates it from questions about policy research and implementation research and actually implementing things at scale to address the challenges of AMR.
Yeah, it reminds me of the conversation that we've been having for the past year or so about pandemic preparedness as well. Because if you think beyond just drug discovery, there's huge investments that are needed in laboratory capacity and diagnostic capacity and surveillance capacity around pandemic preparedness. And one of the questions that we've been asking is, to what extent can we synergize? To what extent could all of those infrastructures that need to be built for pandemic preparedness be used to tackle AMR in the meantime. We keep them running, they do AMR surveillance and other similar types of activities, and then be ready to pivot in an emergency outbreak type situation like we saw with COVID-19. And I think that speaks to Dr. Adetifa's point about wrapping it into the broader question around societal good and all of these things. But it is a challenge. Those laboratory technologies, diagnostics, all of that takes a lot of investment. And so do some of the data infrastructures, maintaining data systems, maintaining living systematic reviews about policy questions that we know we are going to want to keep coming back to and be up to date on the evidence as well. So finding some mechanisms within our research funding, within our government funding that actually can synergize between AMR and all of these other things as well, I think is likely to be the best argument going forward. It's not going to work every time.
Dr. Shroff, did you want to say something? No? Okay, that's great. Well, looking at the time, I think we should probably start to wrap up. I think we've heard a lot of great information around, again, these primary challenges of bridging the research policy divide in the context of AMR. We've heard about a lot of the important considerations to keep in mind, some even potential solutions, and of course, promising ways in which to direct both the design and dissemination of research going forward. I want to thank our panelists for, again, a great conversation, as well as the audience for joining us and for your questions. As well as to Demetria, Julia, and Kayan for their support in organizing and running the webinar. Again, there is going to be a survey that we have, a small, short feedback survey. We'd appreciate you filling out. But otherwise, I will end it there and thank everybody for joining us. Take care.
Bye. Thank you for having us.
Thank you.